My name is Tim Hughes. Honoured guests, ladies and gentlemen, good afternoon, everyone. Welcome. Thank you all for joining us today and in such great numbers. York Medical Society came into being in 1832, and I am your 193rd president. And it is my honour and privilege to introduce our orator for 2024, Dr. Gwen Adshead. Dr. Adshead is one of the United Kingdom's leading forensic psychiatrists and psychotherapists, with over 30 years of experience in working with perpetrators of violence in high secure hospitals, particularly Broadmoor Hospital. Many of you will know about her from listening to Desert Island Discs, Private Passions, and the Life Scientific and other programs, and from her writing about her work at Broadmoor Hospital. Dr. Adshead is not only a distinguished clinician, but is also an academic of international standing who has held professorships and lectured and published extensively and widely. Her most recent book for a wider readership, The Devil You Know, Stories of Human Cruelty and Compassion, is co-authored by her friend Eileen Horn. Today, we are fortunate to have Dr. Adshead share some of her wealth of knowledge and experience with us through her oration and in conversation with us afterwards. Her talk will no doubt challenge our assumptions and offer us a deeper understanding of how we view mental illness, criminality, and the human condition. Please join me in welcoming Dr. Gwen Adshead.
Thank you very much, Tim. It is an enormous privilege to come and be your, 193rd orator? I'm clearly joining a distinguished band of people, just not on the wall there, also here, a distinguished group of people, and it's a great pleasure to be able to come and talk to you. So I'm going to talk about my life and work as a forensic psychotherapist. And the title of my talk is really about the kind of time I've spent in a high secure hospital. I was just saying to Tim that I spent most of my life kind of working away in a high secure environment. I never expected really that anybody would be interested in this work. But I've had extraordinary opportunities to share something of what I've been learning about people who've killed, and about the motives for killing, and about what happens to people who've killed. So I'm going to be talking a bit about my training, and then I'm going to talk about my work in secure settings. I'm going to give some clinical examples, and then we're going to have some time for questions and your comments and reflections, which will be most welcome. I was just saying to our distinguished Lady Mayoress that in fact one of the things that I find so compelling about the work that I do and still find interesting is that we're working in a domain where most people have a view about things. It's ordinary people have feelings about what's good, what's bad, what makes people do good things, what makes people do bad things. And so I feel very fortunate to work in a field where everybody can get engaged. So I want to start by a little bit of history. Your distinguished president and I met at St. Bartholomew's Hospital. I would like to tell you that we met in the lecture theatre. We were very studious, doing well in exams. Tim tells me that we in fact met at one of the many parties that I had at the house that I lived in with 3 other women. I can remember nothing of these parties. There were a lot of them. We actually locked somebody in the cellar and didn't find him till the morning. And there was a very nice blanket that my parents gave me that somehow got out in the garden on a snowy night. It was not recovered until after January. But also it was a time when I also didn't do terribly well in my exams, and when I had to come to do my resits, I had to blow the dust off my books. So I was an undistinguished student. I had a brief interest in orthopedics, which is, if you think about it, is kind of yin to psychiatry's yang. Orthopedics is all about fixing things, extremely practical, very important specialty. And I had a great teacher, and I really found orthopedics interesting. But later, when psychiatry came along, I kind of felt that that was where I belonged. It felt kind of familiar. And also by that time, I developed a terrible tendency to faint in theatre, which made me absolutely useless as a surgeon. So I had a typical psychiatry training. I went to St. George's Hospital in Tooting, and like many junior psychiatrists, I started my training at one of the big old psychiatric hospitals that dominated psychiatric care for sort of half a century. That, in the 19th century, long stay residential care was the dominant mode of any kind of mental health care. And so these great old hospitals were built, and I trained in one of the Epsom cluster. There were 5, all within about a mile of each other, and I trained at Longgrove Hospital. This is a picture of Longgrove. What they don't tell you about Longgrove is that during the war, a great delivery of plants, shipment of plants bound for Kew, got stopped by a bomb on the road. And so Longgrove Hospital gardens were absolutely magnificent. We had one of the best magnolias in the country, and it was a wonderful sign of spring. And then after Springfield, after Longgrove, I went to Springfield Hospital, which is in Tooting, not quite so beautiful, not so many magnolias. And then I did most of my forensic psychiatry training at a place called Clare House, which is on the St. George's Hospital Tooting site, which is a good place to observe if you want to watch people fighting over car parking spaces. But we honestly spend a lot of time just watching people having almost fisticuffs about parking spaces. Now, I was very interested in medical law and ethics from quite an early stage. So just before I qualified as a doctor, by the skin of my teeth, qualified as a doctor, Ian Kennedy, Professor Sir Ian Kennedy, gave the Reith Lectures called The Masking of Medicine. I see some nodding heads. And I was really struck by these lectures. I listened to them, and I thought that Professor Sir Ian Kennedy was very rude about doctors. I thought he was rude about medicine. And I thought, what does he know? Like you do when you're an undergraduate. I said, what does he know? And of course, once I graduated and became a houseman, I saw exactly what he was talking about. I saw the very profound ethical dilemmas that all of us face as doctors every day. Ethical dilemmas about resources, ethical dilemmas about access to beds and treatment, ethical dilemmas about consent, ethical dilemmas about confidentiality. And I was really gripped by ethical dilemmas in medicine. And especially I was interested in how our values as doctors might really affect the care that we give people. And as I went into psychiatry, I was interested, of course, in the values that influence psychiatrists, because psychiatrists are given enormous powers over people. And there are aspects of psychiatric care which are very much looking at how people live and what kind of people they want to be, not just, are you better? And psychiatrists also have quite an influence on what better looks like. So I was interested in how that might pan out. So I wanted to try and get some more experience in medical law and ethics. And I went off and did a diploma and then a master's degree in medical law and ethics at King's. And I actually taught by Sir Ian Kennedy, who was and is a very clever, funny man. And then I started to get interest, of course, in justice, because as a forensic psychiatrist, I was going to court and giving the court advice about the mental state of defendants and how that might affect their guilt or innocence, how that might affect decisions about sentencing. Should a person be sent to hospital instead to prison? The learned judges in the courts need to make these huge decisions on our behalf, and they need good quality expert witnesses to do that. And I learned how to be an expert witness as part of my training in forensic psychiatry. So the questions there, of course, are about so often whether mental illness can, as it were, make you do bad things, or whether you still retain some element of choice. And what about violations of ethics in psychiatry? And this is a memorial at Reichenau Hospital, which is a very big psychiatric hospital in Constance, which is just in Austria. It's right on the border. It's right on the end of Lake Constance, so it's almost in Switzerland. And this is a memorial to the 508 patients who were murdered at Reichenau under the Nazi laws about life unfit to be lived. And it was the doctors and the nurses who were involved in those murders. It wasn't the SS, it wasn't Nazi stormtroopers, it was the staff and professionals at the hospital who oversaw the euthanasia of those patients. So I often joke now that I came to forensic psychiatry for the philosophy, but I stayed for the stories. And I realized that if I really wanted to understand the people that I was meeting, the people I was interviewing in relation to their criminal charges, the people whose risk I was being asked to assess, the people I was going and seeing in Broadmoor to see if this person is safe enough to move to lesser security, I was going to have to listen to what they had to say. I was going to have to develop a capacity to listen, as well as to speak. So I trained as a psychotherapist. And from then on, I decided I was always going to work with offenders. I also realized that as a consultant psychiatrist, that if I didn't train as a psychotherapist, I would probably never talk to a patient again. That actually I would be sitting in ward rounds and I'd be overseeing treatments and I'd be listening to what the nursing staff told me, very important. I'd be listening to what my junior doctors told me, also very important. But I would not be doing the talking myself. And I didn't fancy it. Truthfully, I just didn't fancy it. So I decided to go and do something a bit different. I was lucky at this point to have a bit of a gap. I went and did some academic work at the Institute of Psychiatry, learning about trauma. And that gave me a bit of a space to start my training. I trained as a group analyst, but I've also done other kinds of individual trainings as well, because I think that, you know, we are social animals. So we need to understand ourselves in terms of our group interactions, our social interactions with others. But of course, we have a very strong individual sense of self that operates in a kind of figure and ground, if you like, between the individual and the group. So after a while, I arrived at Broadmoor. I came first to Broadmoor as a senior trainee, and I took up my first consultant post as a regular forensic psychiatrist in charge of a couple of wards. And then I was appointed to a consultant's post in 1998. I left in 2013 after a little local difficulty about closing down our department. But I came back in 2018. And again, it was generally thought that I had failed my community leave and had not maintained my rehabilitation gains, and so that I had to be recalled. This picture is what most people think of when they think about Broadmoor. They think about 19th century, kind of Gothic, kind of dark, kind of scary. Yeah, and there's a picture of the old 19th century buildings. What a difference colour makes to how the picture feels. And I just want to flag that up really because so often when people think about secure psychiatric buildings, they do think about them in black and white, both black and white in terms of morality, but also black and white in terms of about the lack of light and shade. Something terrible is happening. And this view is a beautiful. This is no longer, well, it does exist, except it's going to be presumably made into flats. You heard it here first. You can buy one now. It has the most amazing view over 3 counties, an absolutely priceless view, but it's some way off yet. And what you see there is the long terrace that patients and staff used to walk up and down. You can see also a conservatory built on the end of one of the house blocks. And this was the building that I came, these were the buildings that I came to work in. And then that all changed again in 2019. The old 1863 buildings were closed down and replaced by this. I think it looks like a municipal airport, and it does have kind of similar kind of airport security. So that's where I go to work on a Monday. And I believe that it is reasonable to call Broadmoor the OG of high secure hospitals. For those of you who are not familiar with the term, I believe the proper translation of OG is original gangster, or original grandparent, depending on your choice. But Broadmoor is certainly it. It is the first high secure hospital that was built in the UK, with 500 beds to accommodate the growing population of the criminally insane. At its peak, we had 945 beds. I wasn't there then. There were some women there too. In fact, women were some of the first arrivals at Broadmoor because there weren't any beds for women at Bedlam, at the Bethlehem Hospital. By the time I came to be appointed, and we were down to about 500 people, of which there were 400 men and 100 women. Then in 2003, the women's service closed. Because it was entirely reasonably because we now had medium and low secure services all over the country, and most women don't need high secure estate. And so now we only have 200 beds at Broadmoor, well, 203. We have to keep a few spare for emergencies. So it's a very small service that I work in now, quite unlike the old institution. So if you think about Broadmoor, Broadmoor is really a place for people who've caused other people very high levels of fear and distress. I mean, psychiatry generally tends to deal with people who cause other people anxiety, but forensic psychiatry in Broadmoor and Rampton and Ashworth, these hospitals deal with people who have caused other people really high levels of distress because of the serious acts of violence that they've committed. And usually they're deemed to be mentally unwell at the point that they committed that violence. We also admit men who are serving a prison sentence of violence and who then become mentally unwell. So, for example, we admit quite a few people from HMP Wakefield, where there's a close supervision unit, and quite a number of people who become seriously mentally unwell while they're serving a sentence there. We also take people from less secure units. So in our local medium secure unit, which is in Ealing, if they have somebody who they can't manage, then they'll be transferred to Broadmoor. So the 200 or so men there are a real mixture of people who are hard to handle, who are hard to manage, and people who've done horrible things. Say women have their own services. Women do commit acts of serious violence, but they're not generally judged to require that kind of security. But the men who come to our hospital in general have either killed someone or nearly killed someone, and that's the bulk of our population. So what else do we know about the men who come to our hospital? Well, for a start, they resemble violence perpetrators generally, and most violence perpetrators are young and male and have histories of substance misuse. Those are the first kind of general things that you need to know about violence risk. If anybody asks you to assess violence risk, those are the first things that you look for. But of course, they don't tell you very much. The denominator of people who are young, male, and drunk is huge. But I've seen quite a few of them as I was walking up. So absolutely delightful, but that denominator is not going to tell you very much about risk, which is another reason why it's really important to focus, I think, on the details of what people say about their violence. So one of the other things that we know about perpetrators of serious violence is that many of them have been exposed to very high levels of childhood trauma, compared to people who have not been exposed to this level of childhood trauma. There's a nice study shown that in most prisons, about 50%, about 50% of the guys there will have had very high levels of childhood abuse, whereas in the general community, only about 10% of people have experienced that level of childhood trauma. So there's lots of interesting questions about the relationship between trauma and violence. Most of our people have had long histories of mental illness, but not all. And many of them have had criminal histories, but not all. So we do quite regularly admit people who have never done anything in their lives until they become acutely and severely very mentally unwell, and then commit acts of serious violence. And sometimes those acts of serious violence are bizarre and unpredictable and catastrophic and come out of nowhere. And that also is a reason why people often get admitted to Broadmoor, because of the nature of their offences. Most of our people are detained under the Mental Health Act, under Section 41 of the Mental Health Act. I'm sure you're all extremely familiar with Section 41 of the Mental Health Act. Use it all the time. Of course not. Section 41 is an order that the court imposes, and it allows for a person to be detained under the Mental Health Act without limit of time. And what that without limit of time really means in practice is that a person who's detained under Section 41 can't be moved anywhere without permission from the Ministry of Justice. So this is another way in which the Ministry of Justice liaises with mental health services, looking at public safety. We do have men who are lifers in the proper sense. They're serving a life sentence for murder. They've often received life sentences of varying lengths. I worked with a young man who was convicted of manslaughter on the grounds of murder joint enterprise. And that means he was present at the time of the killing, but didn't actually do anything. But he was convicted of murder. He'd never had a criminal conviction in his life before, but he was involved in dealing drugs. And he got a life sentence, but his tariff, the amount of time he had to spend in prison, was 11 years. So that's quite comparatively short. Life sentences now are much, much longer at that. They tend to start at 20 years. So, as I said, nearly all of our guys are under Ministry of Justice control. Nearly all our guys have killed or nearly killed. And so they need time. They need time to kind of improve their mental health, but also look at their risk. So there's a certain amount of killing time while waiting. Many of our people stay in hospital a very long time. I'm required by my trust to tell you that the average length of stay is 5 years. So I've told you now, it's not true. It's not true. But apparently length of stay is a key performance indicator for our trust. You would have thought that sort of mental health outcomes might be a key performance indicator. What do I know? Length of stay apparently is the, if you stay a shorter length of time, apparently that's better. In a high secure hospital, maybe. Anyway, the average length of stay is about 8 years, but a third of our men have stayed for 10 or more years, and that's usually because their mental health has not improved. They remain seriously mentally unwell, and we also have a number of men who really kind of can't give up using violence when they're upset or angry. And they take that out on our staff. But that, of course, makes it very difficult to rehabilitate them. We do have about 15 or 20 men leave each year. We also have a waiting list to come into Broadmoor, like one of the better public schools. We don't charge VAT either. So most of our people go on to less secure units, or they go back to prison. And we offer them a range of different therapies. We offer them individual therapy, and we also offer them group therapies, as well as all the creative therapies, which are marvelous, occupational therapy, and of course, medication. So I want to invite you now to just think about time, the spending of time. Imagine yourself as a patient in a place like Broadmoor. Imagine that all the time that will lie ahead of you now, without a diary or a phone or a computer, all the time that lies ahead of you. And we have questions in the hospital which go to chronological time, to the future. Questions like, will he do it again? Is he still a risk in the future? But I think there are other kinds of time, the moment of lived experience, the moment of relational experience, when we talk to each other as people, which you might think of as kairos. a different kind of time, defined, I think, beautifully by C.S. Lewis as the present is where time touches eternity. And that present moment experience is often what we're exploring in therapy. So I remember being in a therapy group with one of our guys, and one of the patients turning to me and saying, "Are you here?" As if, I think, really wanted to know that I was listening and kind of present to what he had to say. So we have big questions about time. I joked rather meanly about length of stay, but there is a question about what people do with their time while they're here. If you're going to detain people for a long period of time, what are you going to do? What are they going to do with their time? How do they spend their time profitably? What do they get for their time that's spent? So we talk about people getting better, getting less risky. But so we talk quite a bit about the future, but there's also this question about what about now? What about the lived experience now? So when we started our homicide group, which I'm glad to say is still running 20 years on, I had a man who came to join us who said, "What will I know at the end?" Such an amazing question. If I come to this group, what will I know at the end? Which rather begs the question, of course, what do I know now about myself? Just to tell you something about our leavers group, we set up a leavers group. Sadly, this isn't running anymore, partly because our rate of people leaving is much less. And so these are men who were on the point of leaving often after a long time in Broadmoor. So these are verbatim quotes from our group. "Not having a structured day is a killer. I'm worried about this form I have to get. It's my P45 or something like that." I thought it was lovely. Can I just get P45 from Broadmoor? I haven't got my P45. I'm fed up with myself. I don't want to be me. I want to leave that part of me behind. I'm living in hope of freedom from my mind. It's beautiful kind of use of language if you can stop and listen. "It feels like a waiting room," said somebody entirely reasonably. And of course, what we said was, yeah, it's a bit like that, isn't it? You're waiting to go on a journey from Broadmoor to another hospital, and you'll be leaving familiar people and routines behind. And what baggage will you leave with us? We used to talk about. Where are you going? When will the leaving be? You see, because we're a high secure place, we can't tell people when they're leaving. That's the same in prisons, which means that the men don't get any notice. They get kind of general notice, but it can literally happen in 24 hours. So it's a bit like a disappearance, a bit like a death. And for many of our people, they're very attached to the hospital, and the transition can be quite difficult. That's a picture of the inside of the hospital, as the old hospital as it used to be. And I love this picture. It's taken by one of our photographers in the hospital. And I just think it's such a beautiful exemplar, really, of the idea of a space where people walk around. In the old broad buildings, you see lots of people walking around. We see much less than we used to. So in 2004, we started a therapy group for people who killed a family member while mentally ill. This came about because I met some marvelous colleagues in Connecticut who'd set up a similar group, and I thought, that's a good idea, let's do that. And luckily enough, I had lots of lovely colleagues at Broadmoor who said, that is a good idea, let's do that. And I'm glad to say that that group is still continuing. We call it the Thursday group, partly because there were some debates about calling it the homicide group. Well, you know, we met quite a bit of resistance to setting up the group, and so, well, you can't call it the homicide group. Why not? We've got a sex offenders group. That kind of gives it away a bit. I mean, but, what's wrong with the homicide group? Well, then they'll know that they've killed somebody. You think? Sometimes hospitals can get very anxious, and Broadmoor is an anxious place. We used to have a sign on the canteen door that said, "This building is alarmed." So the Thursday group is for people who've killed a family member or a friend when they were mentally unwell. The Friday group is for people who've killed a stranger, just in case you want to know. So the people who come to the Thursday group, all they've got in common really is that they killed somebody that they were very attached to. That's all they've got in common. No more, no less. And the focus of the group is really helping people to tell the story of how they came to kill and what their life has been after the death of their loved one. So this is what we call in the jargon the index offence. That's the offence that gets you into court and thereby to prison or hospital. So we spend quite a bit of time helping people to name what they've done, helping people articulate that, put something into words. My index, people often talk about, or was my crime. And people often talk in a slightly passive voice. So they'll talk about when they died, of the person who they killed, when they died or when they passed away. And one of the shifts that we see in therapy is when people move from the passive voice to the active voice. So it's huge, really, when people are able to see when I killed so-and-so. And sometimes that's a very important part of the role that we play as therapists to help people do that. And the story I tell now is not the story I told then. Is something that one young man who'd tried to kill his entire family said to me when he was leaving the group after several years in treatment. This is Magritte's Companions of Fear, which is weird, but interesting, and a bit like my work at Broadmoor, I think, in many ways. And I wanted to tell you something about the first year of the homicide group. So this is a verbatim quotes from the first year. So this is a patient saying, Sam's been talking about football. And somebody else says, well, if Sam talks about football, it's not relevant. And then one of the therapists says, well, we get to know about him as a person. But this isn't the getting to know each other group, it's a homicide group. And then somebody else says, why homicide? And another person says, yes, why? Why not murder? And another voice says, I don't like murder. And then another voice says, you make it sound so serious. Somebody else says, murder sounds so graphic. Somebody else says, why is everyone so fascinated by murder? Waking the Dead, Midsummer Murder. Every night on TV, you can watch something about murder. And there's a little pause. And one of the members says, if you get 7 or 8 crows together, you call it a murder. And then somebody else says, in Broadmoor, there's a myth that the crows are the souls of dead staff. News to me. But these extraordinary kinds of discussion are what happens if you put people in a group together and tell them that you want to create a space where it's going to be okay to talk about homicide. So you can see these are people who are feeling their way to finding the language to talk about something terrible. And I am afraid to think what I've done, is what many people say. And so we are often helping people who are afraid to think. We need to go slowly, we need to go steadily, we have to be secure, we have to make it safe. And my old boss and teacher, Murray Cox, who really taught me a lot about being a therapist with violence perpetrators, used to call it a scala integrata, a kind of staircase where people move from saying it wasn't me. And then they say, well, it was me, but I was mentally ill. And then they say, I did it when I was mentally ill. And then they say, you know what, I did it. There's something about the ownership of agency and autonomy, which is a very important part of taking responsibility for things that you've done. But I must say in the homicide group, we wondered if it was more like a via dolorosa, that coming to the therapy group was actually quite painful for them. So they were kind of facing up to life after death. And some of the questions that we found ourselves wondering is, would they ever be allowed to forget what they'd done? Could they ever forget it? Would they be allowed to forget it? If they had good lives in the future, would that be okay? Who was going to say no to that? And one of our guys who killed his girlfriend when he was very psychotic said, if I can make something of myself, then she will not have died in vain, and 2 lives will not have been lost. And then another of my patients, you could be an ex-bus driver, but you can't be an ex-murderer. And there's something about the stickiness of this identity as an offender which really influences and affects the whole rehabilitative process. So you've heard, no doubt, of the idea of a recovery movement as a big idea of, in the 70s and 80s, a kind of the idea of recovery after mental illness and an influence on kind of making good your life after when you're recovering from something. And recovery in mental health has been a very useful concept, but it has a very special kind of quality to it when it comes to forensic psychiatry. So this is a quote from another project, where the first person is someone who has a diagnosis of paranoid schizophrenia. And he says, if you've got something wrong with your personality, you can't really recover from that. And then somebody else in the group who does have something wrong with his personality says, no, but you can change it. If it's a personality disorder, which has an effect on yourself and others, then you need to change that. So it's about discovery, not so much recovery. And that's a very interesting idea if you think about a discovery of a new way of being a person. This is one of my favorite quotes. This is from the third year of the homicide group. So you've got to imagine Henry. Henry's been in the group from the beginning, and the group often begins with discussions of what they've been watching on television. So Henry begins and says, well, sometimes it feels like I'm on the Enterprise in Star Trek, with the prime directive. And we're going, what's that, Henry? What's the prime directive? Henry says that you shouldn't interfere with new worlds and civilizations. When you arrive on a strange planet, you're not meant to interfere with the inhabitants. And I can't help myself, really. And I say, Henry, isn't that what we do in this group? Kind of explore strange new worlds and boldly go and affect the lives of the inhabitants. And Henry looks at me and says, you do know that I don't actually think I'm on the edge. And what I love about this is that Henry had a very long history of mental illness, severe mental illness. And he had killed somebody he loved when he was grossly psychotic. And he had taken a long time to recover. And it had been very, very painful. And for him to not only tease me, the therapist, for a kind of clunky metaphorical association, but he was also saying something very profound about his own experience of being mentally unwell, and about how his awareness of how mistaken you can be when you're seriously psychotic. So there's something here for me about identity and narratives that comes out in therapy. We have some good quality research that suggests that successful therapy is associated with narratives that have a greater coherence and enhanced sense of agency. And what I mean by that is, if you ask a group of people, who feel they've done that, their therapy has been successful, if you compare them with a group of people who don't feel their therapy is successful, the people who've had a successful therapy say, I feel kind of like myself. I feel like I have more agency. I feel like I can make better choices around myself. I feel like I'm still the same person, I just think differently. And that's very much what we're aiming for when we're working with offenders. We're looking at trying to reduce incoherence of mind and speech. We're looking at trying to, the contradictions that people don't think about. We look at gaps in speech. We listen to language very carefully. And that's one of the things that I wished I learned a lot earlier, which is about the importance of really listening terribly closely to how people speak, not just the content of what they say. Because in a way, what we do is to dismantle people's cover story for what they did and help them build a new, deeper, richer story. And here's a nice quote from what I mean about coherence of narrative. This is from a man who, again, tried to kill his whole family. I feel I'm stuck in my previous age, the age I was when I did my offence. See the passive voice there? Time's passing here and there are things I'm not doing. I want to capture time with magazines and pictures to show what I was doing when I was here. What will it be like in 10 years' time? Where will we be? What will I think on my deathbed about this time? And how many of us have asked ourselves the same questions about experiences, very important experiences, your first child, when your parents died, when something really important happened in your life. These are the kind of questions that we ask ourselves. What am I doing? What am I thinking? What will I think about this in the future? Whereas incoherent narratives tend to have lots of very strange linguistic aspects to them. There are kind of lapses in the way people think. There are lapses in the way people speak. People often change the tense of the way they speak. They may use odd associations, odd metaphors. Sometimes the language is so confused you just can't follow it at all. What we often see too in people who've killed traumas around death or damage are often confusions about whether somebody is dead or not. So here are a few quotes just to make the point. This is somebody I went to see. Yes, this is someone I went to see and asked him if he wanted to join the homicide group. I didn't kill anyone. You can dig him up and ask him if you don't believe me. Kind of giving it away there, Jim. Did you see on the news about the man who killed his wife while he was asleep? He'll be devastated when he wakes up. It was like the world falling away. That's somebody talking about what it was like to have killed somebody in his family. And the idea of the world falling away, I think, is a really important one. My mum was part of my index offence. I nearly murdered her, then I killed my dad, and I nearly killed my mum. Interesting that he repeats that. I killed my mum, my old dear. Interesting association too. In a discussion about visits, I killed my mother, so obviously I don't see her. That's a tense shift, and actually a little drop into incoherence. It sounds glib, but actually that slippage tells you that this man is not resolved his distress about killing at all. And then this is a quote from a guy called Jack, grossly psychotic man who was often very obviously unwell still, hard treatment resistant. So he was muttering to himself in a real sort of, casting exemplar of people muttering to themselves. And I said to him, Jack, I can't hear what you're saying very well when it's a mutter. And Jack said, clear as day, I was thinking about the lady I killed and how I would like to say sorry. When I killed my mum, I was mentally ill, but there was no reason for me to kill the second lady. So very clear, moral philosophy 101. What is the difference between being compelled to kill by virtue of a mental illness and killing another similar person for no apparent reason? What does no apparent reason mean, if also a slightly different kind of irrationality? So this is all really about finding meaning and paying attention to chronos time and kairos time. And Viktor Frankl's logotherapy comes to mind here. For those of you who haven't come across him, Viktor Frankl was imprisoned in Auschwitz and then in Dachau and managed to survive these things. And when he was released, he became a psychiatrist, a psychotherapist, and wrote several extraordinary works about how to find meaning even in the most horrible of experiences. Something about the discovery of new ways of being in relationships with others by keeping your eyes, ears, and minds open. And in fact, although I'd never discussed Viktor Frankl in the group, somebody in the homicide group came in one day brandishing one of his books and said, "You'll like this. It's right up your street. It's by Viktor Frankl about finding meaning in places like this." So in a way, also what the therapists are doing, I think, is embodying hope as a passion for the possible. And my lovely colleagues, Mark Hilbrand and John Young, who set up their homicide group many years before us, they wrote a wonderful paper saying that therapists, forensic psychotherapists, people, if you work with offenders, you really have to maintain a kind of hope as part of your therapeutic alliance, a hope that it's still possible to have a meaningful life, even if that's going to be in a secure hospital or in a prison. There's something about leveling and about working together with people and putting a human face on the perpetrators, something about that kind of kinship, what Greg Boyle in California is called. He works with gang members who served a long time in prison. He talks about kinship, and we might talk about connectedness, coming together. So what did we learn? What have we learned? What are we still learning? That people who kill are not all the same. They can mourn and be appalled at what they've done. They struggle with shame and guilt. And because they struggle with shame and guilt and the pain of what they've done, they need people to listen to them and to witness and to offer something that we might call radical empathy. Radical because they go down to the roots of things, but also a kind of empathy which takes on board that there are victims of the people you're talking to that need to be held in mind, the other people who've been affected by what they've done. And there's something that accepting a responsibility for violence is really essential to risk reduction in the future, and of course also for better mental health. So I wrote a book about it. I wanted to share something of what I'd learned about the sorrow and the pity of it. I tried to start writing it and I just couldn't get the voice right. I was kind of too in an academic voice and couldn't really do it. And I used to meet up with my friend Eileen, and she'd done creative writing at Goldsmiths, and she'd also been a drama producer at television for many years. And we used to talk about the books we were writing, or in my case, not writing. And I think after a while, I think maddened by my incompetence, Eileen said, "Why don't I help you?" And she did help me, because as a drama producer, she helped me create stories based on the lives of the many people I've seen. So The Devil You Know is a collection of stories about people like the ones I've been describing to you. They're not actual people, because that wouldn't be right, but they are the kind of stories that we hear, and that has a veracity to it. So I'm going to finish by suggesting to you that the aim of all therapy is helping people to speak what they feel, not what they ought to say. And I always like this quote from East Coker by T.S. Eliot, which is, "So here I am in the middle way, trying to learn to use words, and every attempt is a wholly new start and a different kind of failure. And so each venture is a new beginning, a raid on the inarticulate." And that's where I'm going to stop. Thank you very much for listening.
Thank you very much, Gwen. We'd like to open it out to you now for anyone to start having a conversation with Gwen.
Hi there. When I was last in Broadmoor, which must be
At rather than in, I suspect.
well, I was inside, but it must have been more than 20 years ago, because we were seeing a woman at the time. But I felt quite safe. And you mentioned security, and I wondered about your security and how safe and how you feel the structure helps you feel safe or doesn't.
Yeah. Oh no, absolutely. I mean, it's one of the it's one of those myths about Broadmoor, that it's a very, very dangerous place, and you only have to put foot wrong and somebody will be leaping on you, wanting to kill you. But of course, this takes no account of the context of the violence, and also the fact that if our people by the time our people have come to Broadmoor, they're usually kind of settled in some way, and often the admission to Broadmoor itself, as you probably is quite settling to people. So, I mean, I have to say that the most dangerous places I've been have been in outpatient clinics, because anybody can walk in off the street and do anything. You have no idea what's coming through the door. It's no accident that we've lost a couple of MPs that way, because you have no idea what's coming through the door. But in Broadmoor, I can safely say that I've never felt unsafe, not least of all because we take security very seriously. And so, I'll start my therapy sessions by going to the nursing staff and saying, how's Jim today? And if they say, "Not great, Gwen, actually, not great," then I might go to Jim and say, "You okay? Shall we meet today, or perhaps put it off for another day?" Because I'm not going to take risks. Why would I? I wouldn't do anything like that. That would be foolish and bad for Jim and bad for me. Broadmoor, I can safely say I haven't ever been assaulted in Broadmoor. But I always make the joke about at rather than in, because people often say to me, "How long have you been in Broadmoor?" At Broadmoor.
Does it? That was genuinely a wonderful talk. I was very moved by that. Does it teach you much about what it means to be human, how we're conscious, how thinking works, or are they often so disordered that it's difficult to get a feel for what that means, or does it?
Oh yes, I would say so, because you get to see, in the same way that extremes of any pathology often tell you something about normality. I think you learn, for me, it's not unlike being a surgeon, I think. All those years ago, I can't stand up in theatre, but I get a kind of different feel of it, because you start to open something up and you realize how deep and pervasive, if you like, the damage is. But it can take a little while to get there. And I think what I've learned, and still learning to some degree, is something about that. So much of medicine is about calibration, isn't it? It's about how bad is this? This person I'm seeing now. I'm just thinking about your woman, you see, the woman you saw, is she less good, less bad than the last person you just admitted? You know, how deep does her psychopathology go? Has anything happened in it? I think you develop quite a feel for psychopathology, and it's really in the same way like as kind of any kind of specialty. I think you get a real feel for the psychopathological domain, and you can see things that because you've seen them before. So no, I think I would think that actually what it does do is because you see repeating patterns of psychopathology, what it's given me is a profound respect for normality, and the huge spectrum of normality. There are a lot of very different ways to be normal, and very few of them in Broadmoor. Some of them even in the patient.
But does it leave you with a feeling that the difference between what you might broadly call them and us is a vast gulf, or as sometimes in some of my reading, you get the sensation that there might be just a tissue thin layer between what's happened to these people and what might have happened to me had similar circumstances?
Definitely. I mean, sometimes our people have been through, lives very unlike our own. But then you've got to think, if I'd been through that kind of life, maybe I would be in the same situation. I was just discussing a case only recently, in fact, just earlier this week, where we were talking about somebody who'd come here as a migrant from a war-torn nation and had a very, very long time during his childhood as a refugee, going through different war-torn places, hiding in places. I mean, a very traumatic childhood indeed. And you kind of wonder, if I'd been through that kind of childhood, maybe I would have become disturbed as well. But you also realize how complicated things are, how many factors have to interact before something terrible happens, because serious violence is actually comparatively rare. The denominator of people with severe mental illness, for example, is quite large, but the numerator of people who act violently is quite small. So you're looking at the interaction of multiple factors, but you definitely get a sense that chance often plays a part. And chance always plays a part in homicide, because a lot of homicides, are only homicides because the person died. The intent may be to assault them, but the person died. So absolutely, no, I have much less sense of them and us than I did at the beginning of my career. I mean, I think like most people, when I started my career, I kind of assumed that criminals generally, and violence criminals in particular, were kind of an other kind of person. And I think I've been finding my common humanity with them ever since.
I'm Nicola Gillen, it's a GP. Thank you, Gwen. I'm interested in the maths, and I'm interested to know how you explaining your thinking, the change from 900 beds to 200 beds, and whether that's something to do with specific changes in society and treatment, or whether that's just a political framework that you work with.
It's about a change, again, like many changes in complex systems, it involves a number of factors. But basically, it was kind of a good thing, really, because when Broadmoor was built, as I say, it was to take the Bethlem overspill, because the Royal Bethlem was kind of full. And that was coming out of a 19th century understanding that people who are mentally ill that some kind of acts of violence might come out of a disordered mental state, and people might need treatment and help, not punishment. So that was a good thing in itself. But then after a while, if there was nowhere else there was a general psychiatric ward, and then there was Broadmoor. So if you'd killed somebody, you might go to Broadmoor, but you might not really need that kind of security. And one of the things that happened in the 80s and 90s was two things. One is there was a governmental review about secure hospitals and do we need this kind of secure hospital, not least because it's very expensive, but also because a lot of interest in the research about the relationship between mental disorder and violence and the complexities of that relationship. So out of that came a plan to build medium secure units and to have low secure units. So you have a spectrum of security rather than nothing but an open ward and Broadmoor. And so the reason that the Broadmoor went down to be very small was the medium secure and low secure estate expanded. So we probably, I think, about 5,000 medium and low secure beds. And I think that it's complicated because there are some that are lockable that are not called secure. But I mean, your question is a really good one because it should make us think about what it is that we as society want to do with people who need the kind of long-term treatment that we used to offer in the asylums, but arguably, perhaps we're not very good at reviewing and providing rehabilitation. And it is absolutely clear that we don't need more than about 900 high secure beds. And we've only got 5 for women. Yeah, I think it's only 5 for high secure women. They're all at Rampton. So I think what it comes out of a good place, I think, really, about more sophisticated understanding about mental disorder and violence, much more sophisticated understanding about risk, and an appreciation that as violence rates have been falling across Europe, different kinds of violence require different kinds of explanation. And not everybody who's done something horrible is going to need high security. They might be able to manage a lesser security. Does that make sense?
Yeah.
Sarah.
That's a completely different question, really, but you said that language is really important and how they speak and what tense and the subtlety of what they say. How do you manage people that English isn't their first language or don't speak English?
That's really hard. It's very hard, and we're not very good at managing them. And we don't often take people who really can't speak any English because it would be very difficult to manage them. But we do our best. And obviously people who don't speak much English, we try and teach them when they come. But luckily, I would say, that it doesn't happen. I'm glad to say very often. We do have people from different countries, but actually the vast majority of our people are born in this country and speak English well, but they've often missed out on education. And they often, of course, have mixed heritage. And it remains a very worrying aspect of forensic psychiatric services and prisons in general, but forensic psychiatric services in particular, that we have wild overrepresentation of British-born Afro-Caribbean men. And to some extent African men, but that's complicated because those African men are often people who've migrated and then got into trouble. But the British-born Afro-Caribbean men are wildly overrepresented, and that is almost certainly to do with racism in the criminal justice system, which is a whole other topic. But it is a real worry that is a real worry for us.
Thank you very much. I'm a retired professor of health policy, and I helped set up the Inner City Mental Health Trust Group in the 1990s. Theme of chief executives and clinicians getting together to sort of develop grassroots improvement programs rather than just wait for them up there to come up with giving answers and so on. And so I got the view, and we used to visit various levels of security. We got the slightly different view of the high secure units. By people who were practicing in the field with very limited resources. These were like sort of rather special clubs or Oxford colleges with certain people who were thought to be people who should be locked up for very long times were put, and they generated a huge cost. Even at that time, there's a question of why are there 3 of these units? I still there.
Yeah, yeah.
And the feeling was among sort of grassroots workers that the whole system makes it very difficult to look at sort of creative solutions by which, yes, you lock up people who are dangerous, but then say, right, we're going to help you return to a more normal life.
Yeah.
And perhaps find people who want to work with you.
Absolutely.
And have the gift of working.
Absolutely.
And we're going to give you the skills to help you have more esteem in this future.
Absolutely.
Are we blocking sort of creative developments in this field because we have a fairly rigid structure?
No, I do want to answer, but I'm just very conscious that, you know, we could talk about this all afternoon, and it's a really important question, and I don't want to make light of it. I mean, I think those, I think it is undoubtedly true that the high security state exists because the public want it. And this is the public who are the part of the section of the public who are both frightened of people with mental illness, but also people who are vengeful. Sometimes not because they have anything personally to be vengeful about, but because they represent a voice that says, you know, locking up's too good for them, really. And it's kind of a solution to the voices who say, why don't you just kill them? No, and those voices, of course, still exist. So, and that's partly why the high security state, I think, persists. It also persists because there are people that the prison service find very hard to manage, particularly in the last 10 or 15 years, with cuts, massive cuts to prison staff and the ghastliness of the prison estate generally. But my colleagues that you're talking about, I know because I was one of them. I worked in medium security and I've worked in outpatient services. So I know those conversations and I don't dispute them. The only thing I would say is that I think that Broadmoor used to do a much better job about rehabilitating people than it does now. The new build has very little opportunity for rehabilitation because the model, the vision of length of stay, let's get them out, says, oh, we won't do rehabilitation in Broadmoor. They can do that in medium security. However, the colleagues in medium security are saying, what now? Because they've got their own smoke to manage. They've got their own people to rehabilitate, and our people in Broadmoor need much longer. Because, you know, the community, whatever community it is, you know, and the community is not one thing, but the community is often very reluctant to take people from Broadmoor, even if they've been ever so well behaved for a long, long time. And communities have long memories. We've got a guy who killed 3 people in a county in England, and the county in England say he can't come back here ever. He can't come back here ever. You're going to have to put him somewhere else. We say he's fine. You have to put him somewhere else, somebody else. And then, of course, the other places say, oh, no, sorry, we won't take him. We don't have enough beds for our own people, thank you very much. So you hold on to him. And so you know, your question is so complex, but and it really, for me, goes into a much bigger question about what do we do with people who've done the most horrible of things? What should we do with them?
Thank you, Gwen. I think you deserve your reserved piece of walnut coffee. Before that, I would like to invite Paul Blenkeron, our President-elect, to formally give you our vote of thanks. And then after that, we'll all have a cup of tea and a bit of cake. And then Gwen's publisher has actually given us 20 books. That's a knockdown rate. But we're not going to give you the knockdown rate because you're going to pay the Amazon price and give the £4 over to Treasure Chest, which is one of our local charities. So it's the same as Amazon, but Treasure Chest. Treasure Chest is a breastfeeding support charity, which the name was coined by our very own President-elect. Skillful marketing. Over to you, Paul.
Thank you so much. That was a highlight of my career, but it's all downhill from now on. So good afternoon, everyone, friends, colleagues, guests. both here in person and on Zoom, where I'm told, Sarah, if I stand here, people can see me, can't they? So it does give me great pleasure to give this vote of thanks for today's wonderful talk at our annual Oration. And as Tim said, this society was formed in 1832, and its purpose does remain the promotion and diffusion of medical knowledge. And it's a wonderful organisation, over 300 members. So can I encourage any of you that are guests here today and medically inclined to consider joining? We are a group of local doctors and allied professionals. We're here not only to be educated and informed, but to socialise, exchange ideas, occasionally even drink wine, even though it is a risk factor for potential violence, I'm told. So so please have a look at the website. Dr. Tim Hughes, our president, has got a marvellous upcoming programme of amazing events and world-class speakers. Did you write that bit, Tim? No, that was me. Gwen is actually, I think, our 121st orator, because we didn't meet during the World Wars. We had a bit of a break then. I counted down the list on the board here. You can have a look at that. And the first orator was Sir Jonathan Hutchinson in 1890, when I was just a boy. And we've had some really famous names in recent years, and we're going to add you to that list there and there. There's a bit of space left at the bottom, which is good. And I'm reminded of a quote from Sir William Osler, the Sir William Osler, our 20th orator. And he said that in order to appear successful, a doctor should simply look wise, say nothing, and grunt. So I do wonder how his own annual oration actually went down at that time. It does say there. But anyway, I actually know a few doctors today who seem to follow his advice. But seriously, a far more appropriate quote would be Rudyard Kipling, who said, "Words are, of course, the most powerful drug used by mankind." And I think that is really and the essence of today, isn't it, about talking therapies. And I think Gwen has shown that her experience over the past 30 years of treating violent perpetrators, she's been straddling that difficult area that I've thought about quite a lot, between personality and mental disorder, between punishment and rehabilitation, criminal responsibility and mitigating circumstances with a person's past. And I know how difficult it can be to sort of change. So I made a couple of notes here because it's for CPD points, obviously, today. So what did I learn from today? The key points. Well, first of all, Broadmoor is alarmed. That's always really encouraging to know. You can't be an ex-murderer, sadly. But about learning about, oh yes, you're an undistinguished student who fainted in the operation theatre and failed her exam. But it just goes to show we've all got potential for great things later on in life, if there's any students watching or listening to this call here. What I also learned, yes, the power of a picture when you change it into colour. That's interesting. We have our very own institution in York, Bootham Park Hospital, which is also historic. And I think in colour it does look much better. I can vouch for that. So I'm going to end now by, as Tim says, inviting you all to tea and cakes afterwards in this medical society room. And later on this evening, I'm going to invite Gwen, along with the rest of the group here, the society, to join us for our great annual dinner. As we're preparing for the coming budget, this will probably be a sandwich at Pret-a-Manger, because we're trying to, no, seriously, a 15-course banquet at the Principal Hotel. So please, ladies and gentlemen, thank you once again to Gwen for a talk that's been illuminating, entertaining, inspiring, therapeutic, and forward-looking. And I do hope that your P45 is a long time in coming. So put your hands together, please, for Dr. Gwen Adshead.